So to kick things off this evening, of course, we are here tonight with Dr. Karthik Tennankore, who will be discussing itching for new therapies for chronic kidney disease-associated pruritus, CKD-aP. We're very fortunate to be joined by Dr. Tennankore tonight, where he will be covering a variety of topics, including a description and discussion of chronic kidney disease-associated pruritus, a discussion of how to screen and evaluate for CKD-aP, and we'll also discuss treatment options for CKD-aP, including emerging new therapies. Dr. Karthik Tennankore received his MD at the University of Western Ontario and completed Internal Medicine and Nephrology at Dalhousie University. He went on to complete a 2-year clinical fellowship in home dialysis at the Toronto General Hospital and concurrently obtained a Master of Science in Clinical Epidemiology through Harvard University. He joined the Dalhousie Division of Nephrology in 2013 and is a professor in the Department of Medicine and the QEII Foundation Endowed Chair in Transplantation Research. His research interests are aimed at improving the health of dialysis patients and kidney transplant recipients. More recently, he has been studying the burden and impact of chronic kidney disease-associated pruritus on patient outcomes and developing approaches to screening for CKD-aP in the dialysis population. So before I throw to Dr. Tennankore, I do want to bring to your attention this presentation is being recorded, so there's no need to take any rapid-fire notes throughout. Everything, including Dr. Tennankore's slides, will be available after the fact. If you have any questions, concerns throughout, I encourage you to share them in either the comment box or the Q&A box. After Dr. Tennankore's presentation, we will, of course, have plenty of time for a live Q&A, so we encourage you to stick around and hear from fellow PKD patients and loved ones about how this affects them as well. So without further ado, Dr. Tennankore, I welcome you to the floor. Thank you for joining us.
That's great. And I'm just going to double check. Jeff, you can, are you seeing the right screen?
I can see the title slide. Yes, sir.
Perfect. Okay. Well, thank you first for the very kind introduction. And I really appreciate the opportunity to speak today. And, I've given versions of this talk to different stakeholders, health practitioners, and I really think having the opportunity to speak to patients is one that I welcome and one that I'm really excited to do. So, Jeff very nicely highlighted the title of the talk. But before jumping in, what I thought I would do is just touch on a couple of key words or terminology words that are going to be important for this talk. So some of you may have experienced or heard of the itch that's associated with kidney disease or being on dialysis. Now, historically, we used to call this uremic pruritus. And the reason we refer to it as uremic pruritus is there was this belief that if you weren't getting enough dialysis and toxins were building up in your blood, that they could lead to you being itchy. And that was an old term, but it was recognized that, you didn't have to really be under-dialyzed or, need to even be on dialysis to be experiencing bad itch, and itch being a very debilitating symptom. And so as a result of that, the terminology has changed, and we now refer to this condition as chronic kidney disease-associated pruritus, or CKD-aP. So throughout this talk, you're going to hear me mentioning CKD-aP, and I just wanted to make it clear as to the reason why. So as Jeff mentioned, I'm just going to quickly go over this. Really, I have 3 main objectives. I want to very briefly touch on what CKD-aP is and its impact on health outcomes. Talk a little bit about how to screen and evaluate for CKD-aP in dialysis, and I'll emphasize that this is really an area that's emerging and that more work is being done, even here in Canada itself. And then touch on what treatment options we have for CKD-aP, and as Jeff mentioned, including emerging therapies, largely focusing on one that hopefully is going to be coming down the pipeline soon. I think with any talk, it's important to highlight some of my important disclosures. Relevant to this talk, I have done some advisory board and consultation work with Otsuka and some continuing medical initiatives, I should say, with V4 Pharmaceuticals. Both of these are relevant because they work on molecules that are within the CKD-aP space. So what exactly is CKD-aP? So we think about this as being the daily or near daily occurrence of itch. And very often we think about this itch as being something where there isn't another cause. It's not another health condition that's causing it. Now you can see by these visuals, these are dramatic representations of excoriations or scratch marks resulting from CKD-aP in a dialysis population. And obviously, if you're looking at the middle panel, for instance, you can see that some of these have scabbed, they can bleed, and they can really be quite painful and distressing to patients. Now, when we think about CKD-aP, sometimes people wonder, okay, well, is this localized? Is it generalized? Well, we often think of this condition as being one that is symmetrical, typically affecting both sides of the body. But it's important to appreciate that it doesn't follow a very fixed pattern. And even though it may most commonly be symmetrical, it can also be localized. This was a study that was done in 103 patients from 13 dialysis units, and about 84% of them or 85% of them had itching over kind of large continuous areas, sometimes over the back, sometimes limbs, sometimes the chest wall. But that means that a small percentage of them also had sort of very intense localized itch. And I highlight this really to emphasize that, sometimes any itch that one experiences in dialysis when there isn't another clear cause can be CKD-aP. Now, why does this happen? Why is it that our patients who are on dialysis or have kidney disease experience this? Well, it's really still unclear why, but we almost think of it as a pathway from brain all the way to skin. So at the brain level, there's been some thought that maybe dysregulation in certain pathways, including the opioid pathway, may be implicated in itch. You can think a little bit about this in individuals who have been on narcotic medications for a period of time. Sometimes they do tend to scratch a lot and get itchy, and it's thought that stimulation of receptors in the brain might be doing this. There can be sometimes psychological precipitants that push people to sort of scratching or itching more. We think of these as psychologic derived itching things that can happen in really a wide variety of populations. We think about dry skin, so any dry or scaly skin that is a common thing to experience. Even here in Halifax in the winter, we get those situations happening, can cause itch. And then there are a variety of things that result from kidney disease that can stimulate itch. This might be changes along the calcium, phosphate, and parathyroid hormone pathway. There's some thought that histamines can play a role. Of course, this idea that there are these uremic toxins that we don't measure that can build up in the blood and can cause itch. And then we always think about inflammation as a cause. And each of these things can affect nerves or nerve function in the skin that might lead to a manifestation of the need to scratch and lots of itch. Now, as you saw in those earlier pictures, scratching a lot can cause a lot of problems. So you may see big linear scratch marks over the back, often as a spot where patients may not see them because they're often reaching over their back and may not have a chance to visualize that area. These can lead to deep scars and nodules. Sometimes you can get some drying of the skin that's happening at the same time. And then all of this can lead to infection. If you picture scratching your skin, leaving deep kind of marks in the skin, those become openings for bacteria to get into. But I think it's important to appreciate that all of those manifestations can happen in the skin, but sometimes people can just be itchy and have no manifestations in the skin at all. The skin can look completely normal. And this is always really distressing because as a patient, scratching vigorously at your skin, feeling a symptom that's quite distressing. But if a healthcare practitioner comes and sees you and doesn't sort of see anything on the skin, then the emphasis may not be as high on it as being something that's very, severely debilitating. And I think it's important both for practitioners and for patients to appreciate that there can be potentially no changes in the skin at all. It's also important to remember that other health conditions can cause itch in dialysis that may not be CKD-aP. Simply having dry skin is not the same thing as CKD-aP, and it can cause itch. Of course, atopic dermatitis, something that's very common, kind of like an allergic dermatitis in the skin or inflammation in the skin. Liver disease can cause itch. Sometimes based on conditions that people are living in, they're at risk of infestations. and then many, many others. And I thought, relevant to this talk, I'd sort of give a case example that was presented in the literature. This was a 59-year-old female patient who had autosomal dominant polycystic kidney disease and had a 2-month history of worsening pruritus. And her kidney function wasn't poor enough that she was on dialysis, but it was sort of in the lower categories of kidney disease. The itch was so bad, it was interfering with sleep. It wasn't really responding to treatment. And eventually she progressed to the point of needing dialysis. And even on dialysis was continuing to get itch. And even with more intensified dialysis, that wasn't actually helping. Ultimately, things kept progressing. And then she presented with jaundice. So, yellowing of the eyes and yellowing of the skin. And then had imaging done. And that imaging showed multiple cysts throughout the liver. And in fact, this itch was actually the first presentation of polycystic liver disease that was accompanying the autosomal dominant polycystic kidney disease. I say this really just to emphasize that, chronic kidney disease associated pruritus, we think of as a diagnosis of exclusion. We do want to make sure that we're not missing something else that might be treatable or that might need, other specialists' involvement. But once we've ruled out those other conditions, we also don't want to neglect that it's related to CKD-aP as well. So chronic kidney disease associated pruritus is very common, and I'll say surprisingly common. Even as a health practitioner who's been seeing dialysis patients for years, it was always a bit surprising to appreciate how many patients may be affected by this. Now, this was an international study that was conducted in a dialysis population, 21 countries, and about 35,000 patients. Now, on the y-axis, we're looking at proportion, or the percentage of the population. On the x-axis here, we're looking at time periods, so ranging from 1996 all the way to 2015. This is the legend. Orange indicates not at all or somewhat bothered by itching. Blue indicates moderate to extremely bothered by itching, so really bad itch. And what you can see that's quite compelling is if you look back in 1996, about 40% of patients in this international study of 35,000 patients were moderately to extremely bothered by itch. Then if you go, 20 years into the future, you would think, okay, over 20 years, we've come up with all kinds of new treatments and therapies. But no, a little under 40% of patients were moderately to extremely bothered by itch. So 20-year period of time and really no change in the proportion who are experiencing this severe symptom. So it's very common and it hasn't changed much over time. But maybe you're thinking, okay, this is a condition that's mainly in dialysis patients. And I would argue that's not the case. So if you look kind of at the bottom, I've sort of highlighted the categories of patients in these similar bar charts that were experiencing bad itch. So probably more in that moderate to extreme range. And you can see on the right that for dialysis patients, about 12 plus 4, so about 16% in this study were experiencing bad itch. That's sort of the highest level categories of itch. But what was quite surprising is that about 15% of those individuals who had earlier stages of kidney disease, so not as bad that they were sort of at the point of needing dialysis, were experiencing the same severe itch. So it's not really just a condition experienced by dialysis patients, although that has largely been the focus. It's pretty clear that it's experienced by those even before dialysis as well. Now, we know that the itch is common, highly prevalent. We know that it's prevalent both in dialysis and in chronic kidney disease. But what kind of impact is it having on patients? Well, this was a study that was done where patients were surveyed and were asked to respond in 3 categories: never, sometimes, or always. So just keep in mind that always is highlighted in blue. And so when asked the question, how often are you bothered by the appearance of your skin from scratching? You can see that a lot of patients were always bothered by the sort of the look of their skin. Similarly, a fairly high number felt depressed about their itching, and a fairly high proportion felt embarrassed about their itching. And what's really distressing is to just show what kind of impact this itch was having on their social interactions and ability to work. So you can see, about 40% felt that the itch was making it hard to work. And somewhere, between probably about 35% or maybe a little less, felt that the itch made it hard for them to want to be with people and to interact with others. So very clearly, the itch is not just something that's common, but it's something that's having an impact on patients' lives and interactions with others. And if we push it a little further to think about, well, how is this itch maybe affecting other health outcomes that are important? Well, you can imagine if you're itching all the time, it's probably going to be something that you're going to have more attention drawn to at night when you're trying to rest, trying to get a restful sleep. Well, about 40 to 60% of patients that are experiencing itch have restless or disrupted sleep. I mean, that's pretty high. Patients who are itchy are more likely to be depressed. I mean, I think that makes a lot of sense to me. If it's a symptom that's causing a lot of distress, your mood is going to change. Itching causes reductions in quality of life and a low level of energy for patients. And probably the one that's most telling that we always think about is, believe it or not, those who experience itch of a very severe degree are about 1.5 to twice as likely to die compared to those who don't experience itch. Now, you may ask, how does itching, lead to this risk of dying? Well, it does for a couple of reasons. I mean, of course, if you're scratching the skin a lot, you introduce bacteria, you're at risk of having a really bad infection. But there's more to it than that. When you have a condition that's so debilitating, for which hasn't changed over years, where we haven't really had great treatments for it, eventually patients on dialysis get very frustrated by that existence, that life. And it's not surprising to see patients withdraw or choose to stop dialysis when the itch is getting very bad. And when we put all this together, common symptom causing problems, leading to other outcomes, it's not surprising that how to better understand and manage itch was viewed in a large Canadian survey as the second and third most important research area for patients and for physicians. More important than strategies around travel, effects of exercise on dialysis, sleep, depression, lifestyle changes, how to treat other symptoms. So it shows you just how important this one single symptom is for a population with kidney disease. Now I'm going to take a quick pause and stop sharing. Hopefully this is going to work. What I thought I would do is play a video that really highlights from the patient perspective what the experience is with itch. Now, Jeff, I think you're on. When I play this, I might just ask for you to do a quick sound check just to make sure things are working okay. I want to emphasize the sound on this is going to be a little bit quiet just for everybody to know. So put your speakers as loud as you can, and I'll be as quiet as I can here in the background. And it's about a 4-minute video, and then we'll continue the talk.
God, I'm mercy.
You're good, Dr. Tennankore.
I don't know. It's hard. My dialysis is hard. When it started, see this. And I didn't know what they were. So I scratch and scratch and scratch. This is but all this is a scratch, I scratch until it comes like that. That's when we realized there was something wrong. And this is just a part of the deal.
The itch is probably the worst part of dialysis, I would think. I didn't know what it was at the beginning. I thought I had an allergy to something. But then it happened every time I went there. I thought it was just a normal itch. But it kept getting pretty bad. And I asked the nurses, and they said, yes, well, some people get an itch. And they didn't really know what to do about it.
You see me on the chair all day. I'll be going back and forth like that, just to heat my back, because that's my back is itchy. And this arm, rubbing the case, it takes so hard. Sometimes I thought I would sore myself up. How I have to rub it to stop the itching. Because it itches. And it's like that, just it all over my body. And I itch like it's night and day and night. Not just 2 hours, 1 hour, night and day.
And sometimes I'm up till 2, 3 in the morning. And then I go to sleep because I'm so tired. But then I wake up in an hour and I'm back at it. And I can't just lie there because it seems to get worse.
I don't sleep at nights. Probably maybe if I get If the night have 8 hours, if I get 4, I get a lot. I'm always tired because I never get enough sleep due to the fact that the itching is killing. And it doesn't just hitch like say now, it hitches every day.
I love my family to visit, but I think they find too that some days they come and I'm in a great mood, I have a good time. But then if it starts to itch, I get grumpy. I'm not anxious to visit them in their house because I don't know when it's going to happen. It gets too itchy, or I get cranky, and so we have to be.
Well, to be honest, I don't even like to go out because once I go out and I go into places, people see you sit there, see you itching and scratching. You know, people might be looking at you. I don't go to people's house like I used to go to my friend's house. I don't go anymore because I'm ashamed to sit there and keep digging all over my body. I don't, so I just stay home. Honestly, they don't understand. Like my friends don't understand. They can't understand why that bothers me. I say, well, the only thing I can look at them and say, boy, you're not in my shoe. When you're walking in my shoe, you'll understand.
To see your spouse suffering like that. He'd wake up in the middle of the night. He'd be crying about this itch. He'd be, well, I just, and there was one evening when he woke up at night and he was so upset about the itch. He says, I just don't want to do this anymore. And to have someone, oh, I'm going to cry, to have someone say to you, I don't want to do this anymore, it's hard to handle.
I am not saying dialysis is not good because it saves your life. But if you're going to save my life and leave me torment like this, what's the point?
It's tough stuff. It's tough to hear that video, to be honest. Jeff, just want to double check you can hear me okay?
Yes, I can hear you and your slides back up. Thank you.
Okay. So I think what that highlights really is, this isn't just sort of a symptom. This is something that's having a profound impact on patients with kidney disease and those on dialysis. And, I wish I could say that as physicians and clinicians, we're doing an excellent job of capturing this, but I'd say that we have a lot of work to do. This was a large study that was done in the United States, and it showed that in a dialysis unit, about 20% of patients were extremely or very much bothered by itchy skin. This was the highest kind of category of itch. But surprisingly, about 70% of medical directors of these units, when asked how many people they thought were affected with itch, they underestimated the prevalence of itch in their facility. So they didn't recognize it as being as high as it really was. And among those who sort of experienced this really bad itch, a little under 20% of them were on no treatment, no therapy for itch at all. Nothing had even been attempted. So it shows that there's a lot of work that we have to do. And so this is something that myself and some colleagues are working on, which is really developing a better understanding of how we can capture this symptom. And I'm going to talk a little bit about some of our approach over the next few slides. So I think the first most important thing is we have to be aware of this. Talks like this, other experiences like this, we have to recognize that this is a symptom of importance. And, as patients, sometimes you are tasked with helping us do this, but you want to keep in mind that health providers should ideally be asking about itch as a symptom, certainly at clinic visits, especially as patients are getting closer to dialysis, in the dialysis unit as part of our rounds, maybe after major health events, particularly if there have been changes in kidney function. And anytime you're thinking of starting or monitoring treatment, we want to find a way to evaluate itch and itch severity. So a simple approach is to first identify it, ask the question to a patient, do you itch? They say yes, then think about how to classify the severity of the itch. And there's ways we can do that through rating scales. There are then some strategies that look at maybe thinking a little bit about how that itch might be impacting quality of life. These scales are valuable when you're really trying to dive into the impact of the itch, but they may be harder to do on a large scale, only because they do take a lot of time. And then ultimately, it's great to capture itch and to categorize it and figure out how severe it is. but ultimately we want to find ways to treat it. But let's start a little bit with a kind of earlier step, which is figuring out the rating of itch. This is one of the most commonly used rating scales, and it's considered a valid scale. It's been used in a variety of different situations, and it's called the Worst Itch Numeric Rating Scale, or WINRS. Really what the scale asks is, over the past 24 hours, what was the worst severity of itch that you experienced? And that ranges from a score of 0 or no itch, all the way to 10, which would be the worst imaginable itch. And we sort of categorize those who have scores of 7 to 10 as having sort of a severe category of itch, and those of scores of 4 to 6 as moderate. And those are the ones where we usually start to think a lot more about different types of treatments. Now, these scales may be easy for some to understand, but when English may not be the first language, or where there may be difficulties with comprehension, do we have other strategies we can use to capture itch severity? Well, this one isn't quite ready for prime time, but it's really taking that scale and then applying some nice pictures to it to try to help patients and individuals better understand how severe we think these categories are. Myself and others hope to maybe think about how to incorporate a scale like this more broadly in a dialysis population, but as of right now, our tendency is to use the one that I showed you before. So let's say you had a patient in front of you, or you are a patient who is experiencing bad itch. What kind of steps can we go through to manage or treat this? Well, the first thing to always do is if someone's experiencing a lot of itch, is to think about dialysis quality and to rule out any other skin issues. And once those things are addressed, it's then to move on and classify severity. Now, I often hear, well, itch is really a symptom of dialysis, and it's a symptom that will get better if one is getting better dialysis. I also hear, well, itch is usually something that's related to phosphate. My healthcare provider has told me that phosphate's the biggest cause, so if I get my phosphate under control, my itch will go away. What I would say is that in many studies, it's been shown that itch is not really impacted by better phosphate control or by better dialysis clearance. You can have bad itch and have a normal phosphate level and have very good, clearance numbers in dialysis. You can also have very high phosphate and very poor clearance, and you may not be experiencing itch at all. So I would sort of argue that the right approach is to treat the symptom itself, not just the blood work. And you can go ahead and optimize the dialysis and get better control of phosphate. And, if your healthcare provider suggests these types of things, those things can be done, but the symptom should also be treated. So moving through our algorithm, you've assessed that sort of itch severity. If the itch isn't too bad, there are some approaches that can be taken, and I'm going to highlight those in the next slides. And these often include moisturizing creams and lotions. If the itch, though, is very bad and it's generalized and you've ruled out other causes, other skin conditions, this is where we start to think about other skin-related or topical treatments that might be effective. So first, let's talk about some of those conservative measures. And those conservative measures are really helpful for anybody who's experiencing the itch associated with kidney disease. Those things include trying your best to avoid scratching, maybe thinking about things like short fingernails, and even wearing gloves at night. Some of these things may be intuitive, some of them may not be. Wearing gloves at night is probably not something that's easy to get used to, but something that can be tried, because at night, people often scratch without really thinking about it. It's not uncommon to wake up and there's a little bit of blood on the sheet just because you've been scratching all night without realizing. We then think about moisturizing creams or what's called hydrous emollients. But it's not just a matter of putting cream on your skin. You want to think about the right way to do it. One of the things that's been suggested is to make sure you sort of clean the skin with lukewarm water, maybe using a non-fragrant soap, nothing that's going to irritate the skin. Pat it dry. Don't vigorously rub, because that might stimulate the skin to have more itch, and then apply that moisturizer within a few minutes of doing that. And then a final sort of more conservative type treatment, if available, is acupuncture. There have been a few small studies that have suggested that acupuncture might be helpful. I would say that the evidence around this maybe isn't the highest quality, but when faced with something as debilitating as this, if nothing else is working, this may be an option to consider. So if you remember in that treatment algorithm, we talked about this sort of pocket of conservative type treatments, but there are other types of skin treatments that we can think about that may be applicable in this condition. And what I would first say is that in my experience, everybody has a local treatment, something that's done, where they are, that's preferred. And a lot of that preference is based on what's actually available. Some types of creams that you might have heard about, something called tacrolimus cream. Tacrolimus is an immunosuppressive drug, but it may help reduce that inflammation in the skin. There have been some people that have had some effect with capsaicin ointment. Capsaicin is kind of the ingredient in chili peppers that gives it that heat. So it's not surprising that when you use it, you may get an initial burning in the skin. Steroids, I would say, have not really been shown to be all that effective. It's the most commonly prescribed type of skin lotion that people may be put on, but there isn't very good data to support its use. What do we do here in Halifax? Well, we use a combination of a menthol and camphor cream when we prescribe it to our patients as a first step. We sort of prescribe it twice a day to 4 times a day, leaving it at the bedside so it can be used at night. We actually did a study in our center where we took a number of patients. We quantified how bad their itch was. We treated a little under 40 of them with this topical solution. And about 41% who managed to get on that topical actually had a pretty good response. So it's always nice to see a positive response to something that's not another pill or medication. And certainly people have shown other benefits with some of those other topical agents that I highlighted in the previous slide. So let's say that you've gone ahead and you've given this topical, you're not getting a lot of improvement. What can you try next? Well, there are a couple of oral medications, so pills that are available that people can use to better help manage itch. Now, I will say with any medication, one always has to follow the same strategy and same approach. And, for patients on the line here today, I would say this is something that you always want to keep in mind when given another medication. So whenever a pill is being prescribed for itch, I think it's okay to try it. If that medication works, you get an improvement in that itch score, then it's something you can keep taking and just be careful to watch for side effects. If the pill does not work, though, you might see that your healthcare provider or you and your provider work to slowly increase the dose of that medication. But if there's still no response, then the medication should be deprescribed. It should be removed because and I'm sure you'd all agree, you don't want to be on a medication that's, not effective and not working, which may be giving side effects. Once that pill is off, if none of these approaches are working, the next step might be to think about getting the experts involved in the area of skin, namely the dermatology team. Now, what pills work for itch? Well, the medications that seem to have the most evidence are gabapentin and pregabalin. Some of you may recognize these medications as being things that are used for pain, sometimes nerve or neuropathy-related pain. Well, they seem to have some effect for itch as well. It's been shown that other medications are beneficial, tricyclic antidepressants. But one thing I would really emphasize that should be avoided are sedatives. It used to be very common practice that those who were very itchy would be prescribed Benadryl and Atarax. The main reason why would be that these medications, make people more sleepy. So if you're getting a lot of itch at night and you're having trouble sleeping, taking Benadryl might work. Never a big fan of using a side effect of a medication to sort of treat a symptom. So I would recommend to try to avoid these types of medications because they've been shown to not have that much benefit and maybe be associated with more harm because of that sleepiness potential. So this leads me to the last section of my talk, which is really focused on some of this new emerging therapies that might be available. So if you remember earlier on, I talked about some of the mechanisms of itch, and I said that there may be this connection between the brain and the skin through the opioid pathway. And is it possible that changes in how opioid receptors might be working both in the brain and at the skin might impact itch? And sure enough, it's been shown that at the level of the brain, if a certain type of opioid receptor, so opioids being sort of those narcotic medication, pain targets for pain medications, they're being affected in a certain way, that might cause itch. But similarly, in the skin, if a different type of opioid receptor is being blocked, and it's thought that some of the toxins in dialysis may block these receptors, then that might cause itch as well. And so the imbalance of these conditions, blocking those skin receptors, overstimulating those brain receptors, that can certainly lead to itch. And so that brings me to this new medication that is now available. I'd say this is very exciting, but the flip side is it's probably one of the worst named medications I've ever seen. Looking at that, I can't even pronounce it, but it's pronounced difelikefalin or difelikefalin. For the rest of this talk, we're just going to call it DFK for short. So what is DFK? Well, it's actually an opioid medication, but it doesn't work on those brain opioids. So it's not like a typical kind of narcotic pain medication. Instead, it works just simply on skin receptors, on that kappa receptor in the skin. And by stimulating that receptor, it's thought that it might impact reduction of itch, might lead to that itch kind of going away. It's an intravenous medication that's given through the intravenous line. So therefore, thus far, it's really only been approved in the dialysis population. Now, I will say that there's some work being done to look at it in non-dialysis as well in a pill form. And very importantly, it has no activity at those brain receptors. So you won't get any issues with things like dependency. Now, when was this medication studied? Well, in a couple of very big landmark studies. Now, these were studies that were done in adult patients, so those who are 18 years or older, on hemodialysis for more than 3 months. Now, all of these patients underwent screening where they had their itch severity measured, and provided in the 7 days before they went into the study, the average of their itch scores were more than 4, so kind of in that moderate to severe range. They received either the medication, DFK, intravenously, or placebo. And then they were evaluated for 12 weeks to see what kind of impact this medication had on itch. So overall, in these two studies, about 425 patients received the medication. So what was found? Well, again, we're going to go through a little chart here. So on the y-axis, we're looking at proportion or percentage. And this is what's considered an important reduction in itch. So if you satisfy this, it means you're showing that this treatment has benefit. Green is the medication, DFK, and gray is placebo. And you can see that those who receive that DFK medication, they had a better improvement in their itch scores or a reduction in itch compared to placebo. And to put numbers to this, about 51% of patients, so half of the patients that got the medication, achieved a very important reduction in itch severity compared to those on placebo. Looking at quality of life, I won't make this too complicated, but if we think about one of our quality of life tools where lower equals better, those who received the medication experienced an improvement in quality of life. But I think what was really impressive is that that improvement wasn't just in quality of life related to itch. It was related to things like social function, mood, and emotional distress, in addition to the disease itself. And remember, when we think about how itch is impacting people, it's impacting them across all of these areas. So showing that that treatment is improving those areas means we're actually having an impact. Now, with any medication, there are important side effects. Were there any important ones in this? There were. The side effects were a little bit more in those that got that DFK medication, but not all that much higher than the placebo-treated patients, and included things like diarrhea, dizziness, nausea, and some unsteadiness. But very importantly, there were none of those sort of opioid side effects, narcotic side effects we think about. There was no hallucination or euphoria or dysphoria. And when looking at after 12 weeks, so did this treatment work after 12 weeks? You can see that those that got the medication, their itch got better when they were treated compared to those that didn't. And then at about 12 weeks, they let everybody get the medication. And those that were in that placebo group, their itch got better to the same level as those that were on the medication. And that lasted throughout the 52 weeks that they studied this. And so if we take all of this information together, we come up with maybe a new way of treating itch in our population, those who are on dialysis. So for anybody, You can do all those things that we talked about. You can optimize dialysis, you can treat phosphate in addition to doing skin moisturizing. Maybe if you have acupuncture available, it's something that you would do. And then for those that are really experiencing bad itch, if it's available, using that medication DFK, maybe thinking about some of the other medications that I talked about, and then potentially getting dermatology or the skin specialists involved if we're still having trouble after that. And following patients regularly and measuring their sort of itch severity on a regular basis. Now, do I have any experience using this medication? Well, unfortunately, we have limited access to it in Canada. We're certainly working on it. It's one of the areas that I'm trying to push in as hard as I possibly can. I've managed to treat one patient so far, and this is kind of the general experience in Canada. Only a few patients have been treated. They had really, really bad itch. Their itch score was 7, which is kind of in that severe range. It was affecting their sleep. Tried all kinds of other treatments and it wasn't working. Thankfully, even though this patient didn't have, a good private plan to cover medications, we were able to use some foundation funding to get them started on DFK. Their itch instantly went from 7 down to 2. They had a great response. But despite that response, they were having those side effects, a little bit of diarrhea, feeling a little bit dizzy. They wanted to continue taking it despite it because their itch was better. But we thought maybe we should try to see if we can get them a better balance of those side effects. So ultimately, we used half of a dose instead of a full dose, and their itch was away, and those side effects weren't there as well. So I would say this one patient experience, even though it was only one, was a big success. And I'm hoping we can have more of these success experiences in Canada. So that's all I have today. I'm happy to hear for some questions, but to conclude, hopefully I've highlighted to you that chronic kidney disease associated pruritus, it's not just a symptom, it's a debilitating condition, has very important consequences. We as practitioners need to ask about it and measure it, and patients need to know that this exists so that they're aware to talk to their healthcare providers as well. There are lots of options for management, both conservative, topicals, and other medications. And, this medication DFK and some other ones too are coming down the pipeline. So I'm glad to see that we're starting to put some importance on this symptom. I do have references, obviously, that I can provide to Jeff later on. And with that, I'm happy to take any questions. Thank you very much.
And we're back. Dr. Tennankore, that was a fantastic presentation, very detailed, and I know those in attendance really appreciated the information you shared in such a understandable way. So thank you for that. We do have time for some question and answers, and of course, as we carry on this conversation, if anyone has questions that's on the call tonight, be sure to drop them in the Q&A box, and we'll make sure to get them answered with Dr. Tennankore. You talked about a variety of avenues adding to the itch, and that it's not always CKD. And you talked about liver disease and other factors behind it. Someone in the question box has asked if that also includes, of course, polycystic liver disease, which I imagine is one of those liver diseases that you spoke of. But how would one, in greater detail, say they do have a variety of conditions, determine what is causing the issue? Is there kind of a method of steps to take to get to the bottom of it? Is it a lot of trial by error, or what would you recommend for someone?
Yeah, it's a great question. I mean, I think, I've had the luxury of working in a place where I have the opportunity to interact with other specialists, other healthcare providers in different areas. And, when I think about my population, I do try to take the approach, okay, if it seems pretty clearly that it's related to their kidney disease or them being on dialysis, then the right approach is to treat it like it is and see what the response is, being sure to evaluate them regularly or frequently. If, though, I see something obvious, like maybe they do have cracked, dry hands that looks like that atopic dermatitis, or, maybe there is a concern about a liver condition, maybe they have existing cirrhosis, or I know they have polycystic kidney disease, for instance, then my index of suspicion is a little bit more heightened that there could be another condition. If I see something else that's obvious, then I think it's probably not this kidney disease associated pruritus, why don't I get the dermatology team involved to see them? Or, if I think it could be, they have other manifestations, other features of a liver condition, maybe I'll get, a liver specialist or something like that involved. So I always think this is an area of collaboration where we do need to work with other healthcare providers. But, common things being common when we're thinking about a condition that might be affecting 50 to 60% of our population, by and large, it's going to be one of those conditions that needs to be evaluated and treated. And while I think about these other conditions, I want to make sure I give a fighting chance about treating this chronic kidney disease associated pruritus at the same time.
It's excellent insight. Thank you for that. We've had a question come in with respect to how to manage the itching symptoms specifically while dialyzing. So someone who is obviously, tied to the chair, so to speak, and given the sensitivity of their surroundings, are there specific recommendations that you would have in that specific instance?
Yeah, very hard. I don't have something that's specific to while you're sort of attached to the machine. The things that I can think about though, so if we, and I'm not sure, in those who are already on, say, an oral therapy for itch. So let's say you've been prescribed gabapentin, for instance, for itch. Sometimes what I've seen that's happened is someone's getting gabapentin, they go on to dialysis. While they're getting dialysis, that gabapentin is getting, cleared off, and then they may actually start to develop itch during treatment. Hard to say how best to do it. I mean, you could give a supplemental dose on dialysis, but the problem is it's just going to kind of get cleared off. It's not going to get absorbed in time. So, it may be a little bit around dose optimization, making sure you're on the right dose, keeping in mind that we tend not to like to go more than 300 milligrams. The way I prescribe it is you start at 100 milligrams of gabapentin after dialysis on dialysis days, and you slowly increase to at most 300 after dialysis on dialysis days. But one approach might be to make sure it's being given after dialysis, so it's not, being cleared off and then leaving you itchy for the rest of the time. Making sure you go in with all those sort of moisturized approaches or already applied the topical on your skin. And then just making sure there's nothing obvious that's, metabolic in the electrolytes or anything that might be imbalanced, that might be explaining that tendency to have more itch during treatment.
Okay, that's great insight. Thank you. Throughout your presentation, you talked about kind of the itching scale and keeping track of where you are on that spectrum. When it comes to pain management in PKD, we've talked with Dr. Bevilacqua a lot about keeping a pain log, a diary of sorts, keeping track of when it's at its high, how long it lasted, where it was impacted. Do you recommend those that are enduring this to keep a similar log to try and identify any red flags that may be problematic? Is there benefit to doing that?
I think there's always benefit in looking at, a diary of things that might be making the itch worse or better. Obviously, for patients, those are things that they can, maybe know to avoid or highlight to their healthcare provider. One of the things we're working on right now in Canada is trying to figure out how frequent should we be measuring this itch severity, and what does it mean, and how is it going to be informative and help us deliver the right treatments? Because on the one hand, you can sort of think, well, if I measure the itch severity every day, if there were no treatments for that itch severity, what we find happens is every day you're ranking your itch, but you know that there's never going to be something that's going to come and help you. So eventually you start to become kind of tolerant of that itch in a little way, and it may not rank as high anymore. So it's almost like, and I'd be the same as a patient who had the condition. You almost like bring that scale down to a level that seems to be okay, even though it's clearly not. The flip side is that if you say, okay, I'm going to measure the itch severity twice a year or something like this, you're never going to be able to implement any change or get on any treatments that are going to make a difference. So we're trying to find what that perfect measurement frequency is, where it's practical and can be used, but it's not like overburdening people with asking or answering the itch question every day. And I think what we're settling on is that it may be something that's done kind of on a scale of weeks. So some have suggested maybe we do it every 6 weeks. That way we can, measure it, start on a treatment, give some time for that treatment to take effect, maybe remeasure it a little sooner if we want to increase the pill or something. So maybe remeasure it at another 2-week mark, but ultimately thinking more on a week scale so that, we're giving time for therapies and treatments to work if we're going to make a suggestion or intervention, but not so long that we're like kind of neglecting it altogether.
Understood. Thank you. A question that's come in, we have a few that have come in the chat box. Someone is asking about phototherapy, so UVB light therapy. Can you touch on that?
I can. So, and you probably maybe saw that I mentioned it. I didn't spend a lot of time on it. So UVB light therapy has been shown to be effective for itch, but in very small studies. And again, it's a bit of a quality thing, meaning that we haven't had, hundreds of patients, big, strong studies showing that it's beneficial. But some people have benefited from it. So I've tended to reserve it as like the last line of therapy. There are some problems with UVB. One is it's not available for everybody. So you have to be in a place where it's actually given. And even though it's a short treatment time, it's not very long. My understanding, at least in how it used to be used, is it had to be given very frequently. So maybe even on a daily basis for a period of time to really have an impact. And if you're a dialysis patient coming in 3 times a week to dialysis and then having to travel to a UVB center another 4 times a week or 7 times a week, you can see how that can get quite strenuous. And I've had a couple of patients that we've gotten to the point of UVB, but one of them, he went twice and then he said, I can't do this. I'm expected to go every day and then come here for 4 hours. I mean, my quality of life is worse going down this route. But then I've had another one who got a lot of benefit from it. So I tend to reserve it for lower down on that steps, kind of if all else has failed. When I get that sort of dermatology referral, they sometimes have other potent topicals they may use in addition to UVB, kind of like a combo type therapy. I'll say that if DFK can become more readily available for us, it's like a magic bullet for this condition. And I think it's giving improvement that's kind of better than all of these therapies that we've had so far.
Good. Okay, thank you. And another question in the Q&A box. How does being diagnosed with PKD change treatment of itch versus CKD? Or is there a difference between it?
I would say, I tried to do a little literature search to see if there's any, flavor that patients with PKD, irrespective of whether they have changes in their kidney function or not, are more susceptible to itch, this particular type of itch. I can't say that I convincingly did. I would say that, what I found with PKD is in the absence of changes in kidney function, if a polycystic kidney disease patient is presenting with a lot of itchiness, you may want to think about liver as a possibility, and I highlighted that case where the itch was actually a manifestation of their liver disease more than anything else.
Right.
But if you're a PKD patient who's developing kidney disease and in those lower level categories, I mean, you're going to experience all of the same kind of side effects and troubles of kidney disease as anyone else would. And so I would think that a polycystic kidney disease patient, would still continue to be at high risk of experiencing itch, be it earlier on, like kind of that category 3 or stage 3 kidney disease, or all the way into dialysis. I will say that there are some other health conditions where we see that itch, may be more common: diabetes, older age. Both of these things, tend to be more common. So one might suspect that if you had diabetes as your cause of kidney failure instead of, say, polycystic kidney disease, that you may be a little bit more vulnerable to itch. But I don't think that polycystic kidney disease patients are sort of necessarily at any convincingly lower risk. They are still at risk of developing it.
Right. So on that, then, to talk about kind of determining the difference between patients affected by that, someone has asked the question if there is a variance between male patients and female patients and their level of itch, or is it standard across the board? Do you find one sex is more impacted by itching?
Yeah, it's a great question. We recently actually, we haven't finished this data yet, but we recently looked at itch severity in a peritoneal dialysis population, different type of dialysis. And it kind of mirrors a lot of the data in the hemodialysis population. And it seemed that, men were at slightly higher risk of more moderate to severe itch, but it wasn't a dramatically higher risk. I would say that they were still fairly comparable. It was a small increased risk. And, the study that we did in peritoneal dialysis was an interesting one because it was done across countries, because I often hear the question, well, if I live somewhere else, am I more likely to experience itch? Maybe this is only a North American thing. What if I lived in a humid climate? Would I be better?
Right.
If I lived in a dry climate, would I be worse? I'm getting the impression, based on what I'm seeing in the literature, that if you have the condition, you have the condition, no matter what your race might be, what your sex might be, gender, ethnicity. None of these things really seem to be playing such a big role. They may be small differences in different populations, but we don't want to neglect the condition based on where someone lives or where they're from.
Right. Okay, we have time for a few more questions. We've just got a couple minutes left until we're at the top of the hour. So, Dr. Tennankore, I'll rapid fire a few for you
Sure.
before we wrap up. Someone is asking about using tab-reactin for itch specifically.
Reactin, i.e. a non-sedative antihistamine, in other words, if I'm understanding right. Don't have a lot of experience with it. I'll say that using antihistamine medications hasn't been shown in good quality data to have that kind of robust signal of benefit, strong signal of benefit. It may just be that it hasn't been studied to the same extent as things like Benadryl or Atarax, which are more of the sedating type. So I'd say the jury's out, but on the totality of data that we have, maybe not the best first line treatment. May work for individual cases though.
Okay, thank you for that. So one of our coordinators coincidentally did have liver involvement that has caused a great deal of itching pain. So she's written to me that for 4 months, she was given so much Lyrica, Citrulline, Atarax, and another drug that she couldn't recall. Skin became so sensitive that she couldn't wear a ring, a watch, toothpaste around the lips. The skin was so sensitive it would burn. She had tried Eucerin, Glaxol, but it did nothing. And what she experienced was an itching in the palms of her hands and between the fingers and the toes, to the point that it was driving her mad over time. And what that ended up being related to was a blocked bile duct from a large liver cyst related to her diagnosis. So that's just, again, she is a prime example to what you spoke about, where it is an all-encompassing ailment that is impacting morning, noon, and night, no sleep, and causing a great deal of frustration and pain throughout the day.
What's really interesting about that is, again, treated with the conditions, the meds that we really think about for CKD-associated pruritus, but sounds like another, I sort of showed that case of the polycystic liver disease case. So yeah, so these other conditions can creep up and may mimic it in a lot of ways. And, sometimes it's the unfortunate reality, and it's a sad story to hear, and it's tough to hear someone going through all of that. But I'm glad that it came to a resolution, because, there's another condition lurking underneath here. And the only way that was ultimately identified is tried a lot of stuff and it didn't work. And then, thought a little outside the box to think of another condition. So we do see those things happen as well. And as I mentioned before, it's nice to have that collaborative care where we have other people to help us with some of those diagnoses that may slip through the cracks.
Absolutely. We'll close out with one last question. You've spoken on the benefit of bringing in a dermatologist to be part of one's care team. How do you make that recommendation? Is that something that you initiate with the patient and the nephrologist brings them into the mix? Is the patient out to find their own dermatologist? And then kind of a sub question, do you find those that could benefit from a dermatologist in certain areas of Canada maybe don't have the accessibility to one, right? We'll use the Maritimes as a prime example, and the lack of GPs and wait times for specialists. Does the dermatologist kind of fall into that trap as well?
Yeah, the Atlantic provinces the experience in Atlantic Canada may be very different based on where you are. I mean, I'm lucky to be in Halifax in a tertiary care center where, I'm sitting here on the 5th floor right now, and dermatology and nephrology share the 4th floor. So I have a little bit of a secret access path to the skin doctors. So a couple of quick things. Yeah, I'm lucky, I would say. A couple of quick things on that. I believe that the condition chronic kidney disease associated pruritus is in the kidney domain. It's one that we think is something that is caused by kidneys, and it's leading to trouble. So I feel, as a physician, the way I practice is it's something that I need to try to help patients solve. And so my practice has been to refer to dermatology myself. If I've navigated all these other things and I'm not getting there, certainly if I think there's another skin condition, I'll do that. Sometimes I do, if there's another skin condition, it's this condition, it's something else. With some collaborative care with the family doctor, if they have one, I'll let the family doctor take the lead on it because it's not in my domain. Like if they have, atopic dermatitis, a family doctor maybe can send that referral to the skin specialist. But if it's this condition and I'm down and thinking about, say, UV light, that's going to be something I'm going to refer. Ultimately, the comfort with this DFK medication, if we can get good access to it in Canada, it's going to be in our domain. It's an intravenous medication given in dialysis. So I feel like it's something that we will need to be comfortable with. For those in remote places that don't have access, maybe with virtual care, we'll be able to navigate some creative ways of providing care. We're working on some initiatives where specialists come to the unit and patients don't have to go out. We call it sort of hubs of care. It's a really cool initiative happening out of Manitoba that we're participating in. So maybe we will start to see sort of better attention to bringing resources to patients as opposed to having them go out for them. So I'm optimistic about what the future will hold. Virtual technology is getting better and better, and connecting like this. I mean, I'm in my office and giving a talk to a bunch of people all over the place. So maybe we can transfer this to care and in the case of this condition to dermatology as well when needed.
That's optimistic approach. And the virtual world, we often focus on the hardships of the internet and virtual components and social media, but this is an absolute blessing. So, okay, we'll put a pin in that, Dr. Tennankore. I can't thank you enough for your time and knowledge this evening. I know I speak on behalf of those in attendance that this was a fantastic presentation. So I really appreciate you taking the time to join us tonight.
Really appreciate it. And thanks to everybody for listening.
Great. We'll be in touch, Dr. Tennankore.
Yep.
For those of you still on the line, thank you so much for joining us for our year-end webinar. The PKD Foundation of Canada has a lot of exciting stuff coming down the pipeline in 2024. So I do encourage you to stay connected. If you aren't on our email list already, you can visit npkd.ca or finilampr.ca. Sign up for our newsletters. It's the best possible way to stay connected on all things PKD. And as I mentioned, in the coming days, we will get this presentation up on our YouTube and circulate the link to all of those that have registered and attended as well. So we'll be sure to get you this recording to watch at your leisure. On behalf of myself and the PKD Foundation of Canada, one last thank you to Dr. Tennankore and to everyone who joined us this evening. And we wish you a great night. Take care. Bye-bye.